maintain a watertight globe and maintain a structural integrity of the globe. So we have to clearly explain the patient, even though any trauma is minimal or it's severe, we have to explain the patient about we are doing the surgery, all the procedure to save the eye and not for the vision initially. So secondary goal should be removing any disrupted lens fragment, vitreous, repositioning the uveal tissue, relieving the vitreous incarceration, removal of foreign body, and restoring the normal anatomic relationship. So corneal thickness tear can be a partial thickness or full thickness. Or sedal should be done in every suspected case, and modified sedal using giving compression should also be done in all cases. Even though a partial thickness corneal tear, it's always better to do a suturing because it always reduces the astigmatism and maintain the topographic relationship. So always better to do suture if it is near the visual axis. So whenever the full thickness corneal laceration, always keep in your mind there is a possibility of foreign body. You have to explain the patient initially only, and you have to do the imaging. And if you are planning to take the patient to the OT, you have to give a deep plane of general anesthesia or a peribulbar block without massage. A speculum should be chosen which is not compressing the globe. Bridal suture should be avoided, and you should not use providone iodine that can cause toxicity to the intraocular structures, and ocular surface should be well irrigated. Whenever AC is shallow, you have to give a side port incision, and through that incision you have to form the anterior chamber with viscoelastic. It's always better not to use cannulas and knife etc. through the main wound entry. So we usually prefer 10-0 nylon. We all know this diamond shape. The length of the wound compression actually is equal to, so length of the wound compression is actually half of the suture length. So if you are doing a long sutures, there will be compression on both sides, it's half length. So you can reduce the number of sutures. If you are doing the small length sutures, compression will be less. You have to do multiple sutures. And if you are taking the bite, take bite at 90 degree, and the depth should be at least 90 to 95% of the cornea, and it should enter through the other half also through the 90 degree apart, and then come out providing a wood apposition without gape. So if it is shallow, there will be internal wound gape, and if it is deep and passing through and through, there is a chance of microbial contamination. So all sutures should be 90 to 95% depth of the stroma, and should be 1 to 1.5 meter in length and equal depth on each side. So whenever a shelve laceration, you should oppose the internal aspect. So it should be off in the internal aspect and not in the external aspect of the wound. Should be keep in mind in all shelved incision. You can see the second picture, that is the ideal suturing in a shelved incision. You should try to oppose the posterior part of the wound. And long wound involving the pupillary area, you have to make sure you are making long sutures in the periphery and come short and superficial sutures in the central visual axis. So you start from the periphery, you take long and deep bite. When you go through the central area, make it short and superficial. It gives the better anastomosis and gives less astigmatism in the post-op period. So the main important thing is the planning of the surgery. You find out the first anatomical point, mostly in the limbus in most of the cases. You anastomose the limbus first, then make the wound into two equal halves, then suture on the either side with equal tension. Always try to do no-touch technique. Do not hold the wound edge, that creates the ragged ends. So try to do a non-touch technique, and bury not always. After burying, just make sure that the suture knot is lying just behind the stroma, so that it's easier to removal and there will not be a wound gape when you remove the suture. So in complex wounds, you may have to use bridging sutures or persisting sutures. If it is not opposing, you can use any patch graft or tissue adhesive like cyanoacrylate. So that should be also in your hand when you are planning to do a complex suture. So whenever there's a uveal prolapse, you have to clean the iris or choroid tissue whichever is there. Always try to preserve the iris. Making a side port using viscocannula or using a spatula, you can remove the iris and closely suture the wound. Or whenever there is a vitreous strands, you swipe the vitreous from the anterior chamber, and whenever there is a corneoscleral laceration, as we already discussed, first suture the limbus, then progressively suture the cornea, then suture the sclera. So for sclera, many of us prefer to use absorbable sutures. If it is long wound, you can use even non-absorbable sutures also. So you go through a close as you go technique or zippering technique. The most posterior extension, it is not always have to be sutured. You prefer to leave the most posterior aspect, and should be always be careful the wound that is near the muscle insertion. As you know, sclera is thinnest there. Exploring that area should be done carefully. Thank you for your attention.
Thank you, Dr. Irshad, for excellent presentation of the even the very minute techniques of corneal suturing, how to suture, how to place the knot, and how to approximate the wound. Everything has been explained very well, and all the doubts, everything will be clarified later on. And we'll move on to the next talk. And Dr. Subudhi is also available with us for the conduct of this session.
Good morning to all of you. So now I welcome Dr. Nishita. She's from Calicut Medical College. Yeah. So simply speaking on the bleeding eye, it's a very common thing we come across in our day-to-day practice, and when and how to intervene in hyphema. So it's over to Dr. Nishita. Next couple of minutes yours.
So good morning everyone. I'll be speaking to you on hyphema, when and how to intervene. So as you all know, hyphema is the blood collection in anterior chamber, the most common cause being blunt trauma to the eye. The incidence is 12 per 1 lakh population per year, and the most common age group affected is 10 to 20 years. 80% of those injured are males. These are the common etiologies which result in hyphema. Pathophysiology, the mechanism of injury, there is blunt trauma resulting in anteroposterior compression of the eye with equatorial scleral expansion and limbal stretching with posterior displacement of the iris lens diaphragm. So there is a shearing force over the iris, ciliary body and trabecular meshwork resulting in tearing of the vessels and hyphema. Hyphema can be graded depending upon the amount of blood present in the anterior chamber. Grade 1, when the blood is less than 1/3 of the anterior chamber. Grade 2, blood occupying 1/3 to half of the anterior chamber. Grade 3, half to near total, and grade 4 is total. Then you have the microhyphema, in which there is no layering of blood but circulating RBCs are seen. Various blood tests may be done to rule out any bleeding disorders, and CT of the orbit may be done to rule out intraocular foreign body, open globe injury and orbital fractures when suspected. The treatment of hyphema is aimed at reducing the rebleeding rate, clearing hyphema, treating the associated lesions, and minimizing the long-term sequelae. The treatment consists of supportive management, medical intervention, and surgical intervention. The supportive care consists of rest with moderate activity to prevent rebleeding, head and elevation for the hyphema to settle, and use of eye shield to protect the eyes. The medical intervention consists of pain relief using opioid analgesics and oral acetaminophen. Avoid the use of NSAIDs and aspirin. Cycloplegics like atropine 1% eye ointment is used twice daily, stabilizes the blood aqueous barrier, increases the patient comfort, and facilitates posterior segment evaluation. Myotics are preferably avoided. Corticosteroids, prednisolone 1% eye drops is used 4 times daily to decrease the traumatic iritis associated with hyphema. Systemic steroid oral prednisolone 40 milligram per day in divided doses is found to reduce rebleeding. Antifibrinolytic agents like aminocaproic acid and tranexamic acid is found to be effective to decrease the rebleeding. The mechanism of action is they slow the clot lysis and reduces rebleeding. The contraindication for use include intravascular coagulation disorder, pregnancy, cardiac, liver and kidney disease. They have to be used for a minimum of 5 days because early cessation of treatment will result in rebleeding, rapid clot lysis and rebleeding. The newer medical agents include fibrinolytic agents, that is a recombinant tissue plasminogen activator, is helpful in stagnant clots. 10 micrograms given as intracameral injection is found to resolve the hyphema in 24 to 48 hours. Then transcorneal oxygen therapy is useful especially in patients with sickle cell disease. Humidified oxygen is given at a flow rate of 1 to 3 liters per minute is found to reduce the IOP rapidly in patients associated with sickle cell hyphema. All patients with hyphema should be followed up for the size of the hyphema, the intraocular pressure and corneal blood staining. And most of the hyphema will resolve in 4 to 7 days without any sequelae. Surgical intervention is required only in 5% of the cases. And indications include IOP elevation not responding to medical treatment and corneal blood staining. IOP rise is primarily due to the trabecular meshwork outflow obstruction due to RBCs, inflammatory cells and the debris, also due to pupillary block caused by large clots. The increased IOP will result in transient ischemia to the optic nerve head, resulting in pallor of the optic nerve head and optic atrophy. The corneal blood staining is due to hemosiderin deposits in the cornea, and it is a definite indication for surgical intervention in the embryogenic pediatric age group. Because it starts in the center and clears last in the center, the visual recovery will take about months to years. And in pediatric age group, it can result in stimulus deprivation amblyopia. So an early recognition of this corneal blood staining is important in pediatric age group, and it is an indication for surgical intervention. The sign include straw yellow discoloration of the deep stroma and tiny yellow granules in the posterior stroma with loss of normal fibrillar structure. And when to surgically intervene. To avoid optic atrophy, IOP elevation, surgical intervention is indicated when there is an IOP elevation of more than 60 millimeter mercury for 2 days, IOP elevation of more than 50 millimeters of mercury for 5 days, and IOP elevation of more than 35 millimeters of mercury for 7 days. To avoid corneal blood staining, surgical intervention is recommended when IOP elevation of more than 25 millimeters of mercury for 5 days is present, in case of near total and total hyphemas. To avoid peripheral anterior synechial formation, any hyphemas failing to resolve to less than 50% of the volume of anterior chamber within 8 days has to be surgically intervened, and any case of pre-existing glaucoma needs early surgical intervention. Special mention on sickle cell disease, because in them a mild and short-lived IOP elevations can result in optic atrophy and cause decreased vision. So in sickle cell disease, an IOP elevation of more than 25 millimeters of mercury lasting for more than 24 hours or a repeated spike in IOP of more than 30 millimeters daily for 2 to 4 days is an indication for surgical intervention. Now, how to intervene surgically in a case of hyphema? There are different techniques. The AC washout, clot removal via vitrectomy, IA instrumentation and trabeculectomy. AC washout and clot removal, 2 paracentesis ports are made. Through one irrigation is done, and through other port the posterior lip is depressed so that free flow of liquid blood occurs. It is the simplest and the safest method. The remaining clot can be removed with the help of irrigation cannula. Clot removal with vitrectomy instrumentation. Anterior vitrectomy cutter is used to cut and aspirate the clot. Through one port, irrigation is done, and through the other port, vitrectomy probe is used to cut and aspirate the clot. The cutting care should be taken so that the cutting surface do not face the iris and lens in order to avoid injury to these structures. And this requires considerable experience and expertise. Trabeculectomy is indicated in patients with massive hyphemas associated with tremendous IOP elevation. It is combined with AC wash. It results in immediate reduction of IOP, but the long-term results are limited. Iridectomy helps to remove the pupillary block. The newer surgical, more and more phacosurgeons are resorting to ultrasonic emulsification of the clot But extreme care has to be taken to avoid injury to the normal lens because it can result in cataract. So with this, I come to the end of my presentation. Thank you all for your patient listening.
Thank you, Dr. Nishita, finishing the time. So I think any discussion we can go after, but one comment I would like to say, you said that the hypoma is more common in males, but I doubt now, because females are now very much active. I don't know, it's equal in both sexes, so it's not, sex is not the common, I know. So thank you. I think any discussion regarding this we'll discuss later. After this session, all the presentations are over. Okay, next to.
So next we move on to never miss intraocular foreign body, how to assess. And this talk is by Dr. Sapna Mohan, who has his MBBS from Jubilee Mission Hospital and medical retina specialty from Comtrust Eye Hospital. And at present, she is faculty in the Malabar Medical College, Calicut. Dr. Sapna.
Good morning, all. Today I'm going to talk about how to look for an intraocular foreign body. So intraocular foreign body is typically defined as an intraocularly retained unintentional projectiles that require urgent diagnosis and treatment. It is seen in up to 16 to 41% of all open globe injuries, and the commonest cause being work-related trauma and typically affects young males. So it's a true medical emergency. Failure of diagnosis and delay management can often result in complications like hyphema, corneal scar, traumatic cataract or subluxation, retina detachment, retina dialysis, endophthalmitis, and metallosis like sidrosis or chalcosis. So, describing about the types of intraocular foreign body, we have inert substances like glass, plastic, stone. We have metals like copper or iron. We have organic materials like vegetative matter, cilia, or even caterpillar hair. The most common foreign bodies being metallic and magnetic objects. Coming to pathophysiology, the final resting place of an intraocular foreign body and the total damage caused by a foreign body depends upon multiple factors like size, shape, composition, and momentum. Larger the size and more irregular the shape, more the damage. Composition, vegetative matter are known to cause infections like endophthalmitis, and metals are known to cause inflammation like sidrosis, chalcosis, etc. Greater the momentum, deeper the penetration, more the damage. It is widely known that a foreign body entering through the sclera are known to cause more damage than those entering through the cornea. Coming to history taking, it is a most crucial step because most of the children and bystanders are more susceptible to being unaware of the injury and they may present later. But many people present early if they feel symptoms like decreased vision, foreign body sensation, flashes or floaters. So special attention during history taking should be given to the mechanism of injury, whether it is drilling, hammering, welding, blast injury, whether it is machine cutting of organic matter like wood. This will give us an idea about the composition of the foreign body. In evaluation, it is important to consider that all open globe injuries to have an intraocular foreign body until proven otherwise. We should maintain a high index of suspicion. Most medical legal cases against ophthalmologists are because they miss an intraocular foreign body following a trauma. So in most of these cases, the patients will be innocent bystanders. So it is very important to take a detailed history to identify the intraocular foreign body. Coming to clinical examination, we should record the visual acuity. Special attention should be given to the pupillary shape, presence of RAPD and isochoria. We should look the area around the wound for any localized injuries, lacerations, canalicular injury, or remnants of foreign body. If ruptured globe is suspected, we should not do an applanation tonometry until the primary wound is closed. And we should identify the entry point if it is in the cornea or sclera, and then we have to chart a trajectory path. In the sclera, the entry site will be typically masked by a conjunctival ingestion, hemorrhage or chemosis, with or without a conjunctival laceration. There can be a pigment over the entry site which indicates uveal prolapse. In the cornea, the entry site will show a description of the smooth, transparent surface with corneal edema around the site. There may or may not be positive serial test. In the iris, we can see transillumination, heterochromia, hole at the site of foreign body entry. In the lens, we can see focal opacity at the lodgement, or we can see subluxation of phacodonosis. Iris is ideally examined before dilatation and lens is examined after the dilatation. Fundus again should be detailedly examined after, with an indirect after dilatation to directly visualize the intraocular foreign body in the posterior segment. Gonioscopy and scleral depression should be ideally delayed until we close the primary wound. Coming to localization, now X-ray, it is less sensitive than the CT, but it is done as a part of screening. It is capable of picking up radio-opaque foreign bodies, but it is not capable of picking radiolucent ones. The standard for X-ray series for foreign body include anterior posterior view, lateral view, Waters view, and Calvel's view. So that helps in detection of foreign body. But for localization, whether it is in the anterior segment or posterior segment, we need metal markers like limbal rings or contact lenses with metals. Then Berman, Roper, Hall, Bronson, Turner are various electroacoustic metal locators which are used to pick up magnetic foreign bodies. CT scan, now the gold standard for detection and localization of intraocular foreign body. We can use axial and coronal view slices which are highly sensitive, less than 1.5 millimeter cuts, no manipulation, good cooperation from the patient, even done with open globes. It is not beneficial in detecting smaller foreign bodies and radiolucent foreign bodies. Ultrasound B scan, again, it can detect both radio-opaque and radiolucent foreign bodies. It can be done after the repair of the primary wound. It has got higher resolution, lower cost, and it can produce multiple images at a very short period of time. So what do you actually see in a B scan? We can see a hyperechoic lesion that even persists in a low gain. The corresponding A scan overlay will typically give you a 100% tall spike, and there will be acoustic shadowing, and we can also pick up other concurrent pathologies in the retina like endophthalmitis, retinal detachment, vitreous hemorrhage, etc. So MRI, it is not routinely done in case of an intraocular foreign body, especially not done if you are suspecting a metallic foreign body because it can cause potential more damage, but it is more effective in localizing non-metallic radiolucent foreign bodies like wood and plastic. Now coming to the prognostic factors, initial visual acuity, if it is better, better prognosis. Size and location, larger the size of the foreign body and posterior location are considered to be poor prognostic factors. Size, larger the entry wound, and if the foreign body is entering through the sclera, this is again a poor prognostic factor. Lens injury, if it is present, it is a poor prognostic factor. Younger the age group, worse the prognosis. Presence of RAPD, presence of intraocular hemorrhages like hyphema or vitreous hemorrhage, retinal detachment, endophthalmitis are all indicators of poor prognosis. And certain studies have shown that posterior chamber intraocular foreign body, if not removed before 24 hours, can significantly affect as a poor prognostic factor. Coming to management, we have to protect the globe with a shield, not a patch. Area around the wound should be cleaned of any remnants of foreign bodies. A broad spectrum antibiotic have to be given. A vegetative matter foreign body, if suspected, it should be removed immediately, ideally within 24 hours. High-speed small metallic foreign bodies, they are usually auto-sterilizing, so we can wait a little longer. The most important step is the closure of an entry wound. So if it is an anterior chamber intraocular foreign body we are suspecting without any lens involvement, the pupil should not be ideally dilated or constricted to avoid further movement of the foreign body. Any wound, if not self-sealing, should be sutured. Reformation and maintenance of the anterior chamber should be of utmost importance. And the intraocular foreign body should not be removed through the entry wound. An extra shelved incision, almost the size of the intraocular foreign body, should be created in the clear cornea or sclera for its removal. If there is lens involvement in the form of phacodonosis, subluxation or opacity, we can do a lensectomy done with phaco or SICS. Concurrent diol insertion is not ideally done because of the risk of severe post-operative inflammation, but anterior capsule is retained for future IOL insertion. In cases of posterior chamber intraocular foreign body, we do a 3-port vitrectomy. The sclerotomy site should be ideally away from the entry site of the foreign body. The main goal is to remove the foreign body after removing the adhesions. Before removing the foreign body from the retina, we have to apply lasers around in the surrounding retina for preventing retinal detachment and also to prevent bleeding. Peripheral evaluation of retina and removal of adhesions is also important. In case of an encapsulated foreign body, after dissection of the foreign body, it should be removed using a magnet or forceps. And if the intraocular foreign body is larger than the probe or the sclerotomy site, we have to circumferentially enlarge the sclerotomy. In case of a very large intraocular foreign body, then it is best managed through a limbal incision after lensectomy. So we have to turn the infusion line off to prevent any iris prolapse. Then the posterior chamber intraocular foreign body is brought into the anterior chamber through the pupil, and then a second forceps is introduced through the limbal incision, and it is brought out of the anterior chamber, and the limbal incision is closed. So in most of the trauma cases which are intervened after 24 hours, there is a high risk of endophthalmitis. So we have to give a prophylaxis with intravitreal vancomycin and ceftazidime, the most common organism being Bacillus cereus. So in those patients who are allergic to penicillin, we can even give intravitreal amikacin in the place of ceftazidime. Thank you.
Thank you, Dr. Sapna, for excellent presentation. And we'll have the discussion later. And we'll move on to next one. When the sparkles of joy steals the sight, how to go ahead with the firecracker injury. It's been done by Dr. Nahida Ahmed, who has completed her DNB from Comtrust, and at present she is the faculty in the Malabar Medical College, Calicut. Over to Dr. Nikita.
So good morning. I'll be talking about when the sparkles of joy steals your sight. So who doesn't love a spectacular fireworks? Be it's Onam, Deepavali, Vishu. We all love fireworks, and we saw a very awesome fireworks last week in World Cup inauguration. But when you see a firework like this in the sky, as a doctor, mainly ophthalmologist, we would rather be thinking about injuries. And firework-related injuries can be devastating, and it can even lead to permanent vision loss, limb amputation, and in some cases, even death. And out of all firework-related injuries, globe is the second most affected organ, and it constitutes about 2% of all ocular injuries. 65% of the individuals were 18 years or younger, and 70 to 90% were male, and more than 50% of the population who had injury were bystanders rather than active igniters. And injuries were mostly caused due to malfunctioning of crackers and negligence of those igniting the firecracker. There are different types of fireworks, and homemade or illegal fireworks can have greater explosive powder and can lead to more severe injuries. And most commonly, injuries caused by firecrackers, and firecrackers mainly causes ocular burns and superficial foreign body. And there are some other type of fireworks like a mortar type and rocket type fireworks which have more explosive power and lead to more severe injuries, even rupture of the globe. Now coming on to etiology, it results in mechanical, thermal and chemical injury, and 90% of the injuries were closed globe injury and 10% were open globe, and most common ocular injuries noted were ocular burns, eyelid injuries, corneal injuries and vitreous hemorrhages. So these are the spectrum of anterior segment injuries commonly seen, which includes corneal epithelial defect, hyphema, subluxated lens, cataract, iridodialysis, and partial thickness corneal tear. And in open globe, you get full thickness corneal tear, intrastromal foreign body in anterior chamber, etc. And coming on to the injuries, in eyelid, you can see lid edema and charred eyelashes. And in the first picture, you can see there is massive facial with multiple facial abrasions and multiple foreign bodies in facial subcutaneous tissue. And in second picture in the clinical photograph, you can see superficial burns with sheathing of eyelashes and limbal ischemia in the infratemporal quadrant along with melting of cornea. This injury is a combined chemical and burn injury. And this is the most common presentation in corneal injury, in firework injury. That is, you get multiple stromal superficial foreign bodies as well as stromal foreign bodies. And this patient had multiple superficial foreign bodies in cornea, conjunctiva, and even the subcutaneous tissue, and had to undergo amniotic membrane graft for non-healing corneal ulcer. And in this picture, you can see soot particles all over the cornea with a very large epithelial defect. Anterior chamber, you get traumatic hyphema, and in closed globe injury, you can get posterior synechia with a traumatic cataract. You can also see subluxation and dislocation of lens. In open globe injury, you can get corneal, full thickness corneal wound, corneoscleral wound, for which you have to undergo a primary repair. And also in second picture, you can see there is a corneal tear with iris prolapse and a flat anterior chamber. And in firework injury can even lead to an intraocular foreign body. So these are the spectrum of injuries usually you get in a firecracker injury. And now coming on to diagnosis, you have to take a complete history, which includes date and time of injury, mechanism of injury, type of fireworks, and history of previous ocular surgery, presence of pre-existing defective vision in the affected eye as well as the other eye. During physical examination, you have to document the visual acuity prior to performing any dilated examination or procedure, which is very important even medico-legally. And optic nerve function is to be assessed using pupillary response and color plates. And a complete slit lamp biomicroscopic examination and fundus examination to be done in the initial visit and every follow-up visit. Also, you have to take extra care if there is a global malposition or localized area of chemosis or any disturbance in extraocular motility, because that gives you a clue for the sharpnel entry site. And if you see a low intraocular pressure, it can suggest an open globe injury, and Siddle's testing is to be done to rule out corneal and conjunctival laceration as well as to rule out open globe injury. And coming on to diagnosis, CT scan of the orbit is strongly recommended in case of projectile injuries where you suspect an intraocular foreign body, and we usually ask for thin cut session, that is 1 millimeter session, and all views like axial, coronal and parasagittal views. And it's better to avoid MRI in case of metallic foreign body, and you can do B scan or UBM in order to rule out retinal detachment, intraocular foreign body, and when there is no fundus view. Prevention is always better than cure, and for that you have to always maintain a safe distance away from firework. Try not to pick up any misfires and always wear eye protection and supervise the children. Coming on to management, you have to evaluate for other life-threatening injuries and injuries other than orbit, and you have to co-manage it appropriately with available services. And management depends on the injury that is present, and most of the patients were conservatively managed with around 10 to 12% requiring surgical intervention and 7% with residual monocular blindness. And if an open globe injury is suspected, always protect the eye with a shield to prevent further trauma and examination. And you have to use a CT scan to evaluate for intraocular foreign body. Start a systemic antibiotic, cefazolin or vancomycin. If chemical injury is suspected, pH should be evaluated, and if it's above or below 7 to 7.4, copious irrigation should be done using saline or ringer lactate, and after ruling out open globe injury, particulate matter should be manually removed. These were the surgical intervention usually performed, which includes slit tear repair, foreign body removal, pars plana vitrectomy, lens matter aspiration with IOL implantation, wound exploration and corneoscleral tear repair. And globe exploration usually done in case of suspected globe rupture, retinal detachment and penetrating trauma with possibility of intraocular foreign body. And coming on to prognosis, it mainly depends on the mechanism of injury. Mild injuries like corneal aberration, superficial foreign body has a favorable prognosis, whereas open globe injuries and patient with poor visual acuity at presentation have worse prognosis. Open globe injury can lead to permanent vision loss and even enucleation in some cases. And long-term effect of trauma include formation of traumatic cataract and angle recession glaucoma. So don't let your eyesight be gone in a flash. Thank you.
Thank you, Dr. Nishita. I think we will have some discussion after all the talks are over. Okay, but please be here. Don't go. So may I invite Dr. Vidya? Yeah. So she's the oculoplastic surgeon. Okay. Formerly with Arvind Madurai. Huh? Now with Eye Foundation Coimbatore. Yeah. Yeah, it's a very interesting topic, restoring the pathway, canalicular trauma management tips, keynote address. It's a keynote address. So your time is 12 minutes.
Yes, sir.
Yeah.
Very good morning, and thank you KSOS for having me here and giving me this wonderful opportunity to talk on this topic. I took the liberty of modifying it a little bit. I'm going to be talking about both eyelid and canalicular tear management. So, ocular adnexial injury is a very common case scenario in our day-to-day practice. And we as ophthalmologists, we should know like adnexial injuries need proper treatment, because if we treat it properly, we can prevent lid notching, we can prevent exposure, we can also prevent ocular surface disruption, and we can address the aesthetic concerns of the patient, and we can also prevent the functional problems like canalicular stenosis and epiphora, which is very important. The basic principles remains the same, like we have to take proper history, very careful examination, and we have to prioritize our treatment plan according to our patient presentation. Detailed history should include the mode of injury, because that is going to alert us what we are dealing with. Like in case of penetrating injuries, we should be suspecting some kind of foreign bodies, both intraocular and intraorbital. You heard wonderful talks about that. History of fall, which can also cause globe rupture. Dog bite has got some kind of peak in management, which I'll elaborate in the subsequent slides. Physical confrontation has got a potential medical legal aspect, so that has to be remembered. So we have to have proper documentation of everything, and we have to document the facial photographs also. Injury with hooks, even the blouse hooks, which are very common in Indian subcontinent, and that should alert us to the presence of possible canalicular injury. So I talked about medical legal aspects. The facial injury in general comes in grievous hurt. So we should document everything properly along with photographs. So that is very important. If you're going to be taking our patient under general anesthesia, again, time since last feed is very important, and systemic illness, so that we modify our treatment plan according to the presenting condition. Ocular examination, it's very important. We need to document vision in both eyes, specifically check for RAPD, and always rule out ocular injury and extraocular muscle injury. Radiology wherever it is indicated, and please document everything along with preoperative photographs. Any medial canthal injury, which is medial to punctum, specifically look for canalicular tear injury, either by direct observation or sometimes by probing. Grossly, any laterally displaced wound should alert us to the presence of the canalicular tear injury. So always prioritize your treatment plan. In case of head injury, priority is attending, of course, to patient's general condition. In case of globe rupture, the repair of globe rupture comes first, followed by lid tear repair. Many of these cases can be done under local anesthesia, but in case of children or wherever you have extensive injuries requiring long time to manipulate to repair, probably will be taken under general anesthesia or IV sedation. In case of canalicular tear, perilesional or infiltrative block can preferably be avoided, and we can just go for regional blocks like infraorbital and infratrochlear block. That's the preferred thing, so that we have less of tissue distortion. So I'm going to be sharing top 10 pearls in eyelid and canalicular tear management. The very first thing is thorough wound inspection. Always look for foreign body, because many of these wounds can have small foreign bodies embedded in that, and we should not be missing out those things. Sometimes the lid may appear apparently necrotic or devitalized, but potentially all facial structures has got high vascularization. It's not essential to debride excess tissue. And many of these lid tears appear little larger than what it is because of the unopposed action of the orbicularis. So that should also be kept in mind. And so this is the small foreign body which is in the wound. Okay, so moving on to the lid tear marginal repair, which is very important because proper apposition is going to prevent the lid marginal notching. So what I'm showing you here is a 3-1-1 technique. It's otherwise called far near pass. I'm taking 3 millimeters from the wound, 3 millimeter down, 3 millimeter the other side, 3 millimeter the lid margin, reverse the needle, 1 millimeter on all sides, and tie your knot. At the end of tying the knot, it should be slightly everted. You can look at here, this is the marginal eversion, and leave the suture ends little longer, and take subsequent sutures and include this long end into your subsequent knot so that it doesn't abrade your cornea. So that is the thing. The suture material that I'm using, this is where I'm including the long suture end in the subsequent sutures. So that is very important, so that we do not cause any aberration of the corneal tissue. Right. So this is about the lid marginal tear repair, and the eyelid tears not involving the lid margin. If it is horizontal, it is like any other place, just suture it accordingly. Whereas if it is vertical, so in those cases, sometimes if it is very ragged, we may have to convert that into a pentagon shape so that we have aesthetically more pleasing results. So this is a horizontal tear which I am repairing with interrupted sutures. But rest of the vertical sutures, make sure you excise the excess tissue and then go ahead. So that's about the tears not involving the lid margin. Moving on to the main topic, the decoding of canalicular injury. Any medial canthal injury, we should look for canalicular injury because it can be a result of direct and indirect injuries. And there are no tarsal supports there, so it can cause avulsion of the medial canthal area. So we need to identify that and treat accordingly. The critical factors in the management of canalicular tear would be the extensive nature of the injury and the site of the injury, whether it is proximal or distal. Proximal canalicular tear injuries are likely to have better anatomical and functional results compared to the distal ones, which is close to the medial canthal area. And it is also decided by the critical factors of another coexisting lid abnormalities and ocular abnormalities. And we need to plan our management depend upon presenting one or both canalicular tear involvement. And world over, now the canalicular tear management is with the use of stent, either monocanalicular stent or bicanalicular stent. So I'm going to be showing a video where I'm using a monocanalicular stent. The critical factors here or the essential steps here would be identifying the cut edge of the canaliculus. So first I'm doing a punctal dilatation. This is a 4-year-old child with a canalicular tear. I'm using a lacrimal probe. So usually the cut end of the canaliculus can be identified as a whitish tubular structure surrounded by the pinkish orbicularis tissue. So what is essential is that, let me pause this video. What is essential is that we avoid using perilesional or infiltrative blocks, go for regional blocks. That will distort your tissue lesser and you'll have a better view. So that is one thing. And avoid holding the tissues with a sharp forceps. Use always Q-tube applicators or cotton applicators. Use of vasoconstrictors also gives a blood-free field and proper visualization. There are many techniques to identify the cut edge of the canaliculus, like injecting visco, injecting dye from the opposite end, or use of pigtail probes, which is not preferred these days. But use of microscope with a higher magnification always helps. So that is something that we need to do. And what I'm using here is an oro stent. I do not have any financial interest in this. And I'm inserting that into the cut end of the canaliculus. And I'm going to fast forward this a little bit. Okay, so once this is done, this oro stent, this stent has got a longer tube and a collarette which sits in the punctum. So that can easily give you, almost you don't have to suture the end also. It is just that insert this and look at this, this collarette, it sits next into the punctum. So the insertion is that you can use either a probe to insert into the punctum or sometimes you can just pull from the distal end. If it is very close, sometimes it can cause a punctal tear, so be very careful with that. So what I'm going to do is that I'm going to pull it from the distal end so that I secure it with the, along with the punctum. So this is what I was mentioning. So just pull it out and leave it. Okay. So once this is done, securing and keeping it in place is by 2-3 methods. One, you can do an edge-to-edge anastomosis of the thing, which I'm doing it here. You can identify the cut ends and oppose it and give proper result, or sometimes just give a canalicular stitch wherein you take a skin and orbicularis around the stent and keep it in place. That will also be helpful. So once we are done with that, it's important that we keep the stent for at least for about 6 weeks. Stent removal is very easy, can be done in OPD, under topical anesthesia. Just use a forceps, identify the stent and pull it out. So it's as simple as that, doesn't require any other fancy equipment. So that's what it is. Another important factor is that if we carefully examine our wound and we find orbital fat, that should alert us to the presence of violation of orbital septum. If the same thing happens, this is the orbital fat in the lower eyelid, so that means there is some amount of orbital violation. If the same thing is there in the upper eyelid, that means we should explore LPS. That is an important finding that we should need to keep in mind. Do not suture the orbital septum because that can cause some kind of restrictive retraction of the eyelid. That's an important finding that we need to do. Many times patients present with irregular apposition, so they usually require reconstruction to have pleasing results. And dog bites require special mention because these are common in children. Copious irrigation, rabies prophylaxis, tetanus prophylaxis, and infiltrate the wound with local immunoglobulins and then go for primary repair. Systemic antibiotics are usually required to prevent wound contamination. Remember the complications like post-traumatic ptosis, pyogenic granulomas, medial canthal distortion. Sometimes you have this kind of abnormal eyelid with the potential exposure keratopathy. So remember these complications and try to do a good job. And it is time consuming, it is challenging, but it gives the most gratifying results like this. Meticulous repair is what is required in your lid tear management. Thank you so much for your patient listening. Thank you.
Thank you. Thank you, Dr. Vidya, giving us the elaborate management of a canalicular tear. Any question? We'll take one question here. Please be here. Yeah, I think we'll have one question. We've got 5 minutes time. So one question each to each speaker. Any audience would like to ask? So I think the canalicular tear is very common in day-to-day practice. It varies from child to elderly people. So is there a management difference between the elderly person and the child? Only except that it should be done under general anesthesia for children?
No, sir. Some case of children will have a smaller punctum. So you have to dilate the punctum and go ahead with that. So sometimes if you over-dilate that punctum in children, it can cause extrusion of the stent. So that is one potential complication that can be there. The same goes in for adults also, like the puncta may be patulous. So if you put in the stent, sometimes it can go inside, migrate inside, and that can be a problem. So those are the two differences.
Do you think the stent is a must in all cases?
Absolutely, sir.
Huh?
To have
in all cases of canalicular tear,
yes,
you should
whether it is upper, lower, both always use a stent.
So you should have stent with you
all the time, sir.
Yeah, practice.
Yes, sir.
Okay. So, yeah.
Very nice presentation.
Thank you, sir.
How long after that putting that stent we will remove it?
So I remove by 6 weeks. But
6 weeks.
yes, sir. Literature says you can keep it 3 months to 6 months also. It's not usually required. By 6 weeks, healing is complete.
There is no urgency in removing that.
No, sir. So you can remove by 6 weeks.
And the other end will go to the nose.
Almost to the nose, sir. Yes.
And they will
It is
be
almost
touching,
40 millimeters.
Touching the original position of, inferior meatus.
Yes, sir. But the removal is always from the ocular surface, not from the nasal end, because we have a collarette, so it is always from the ocular surface.
Thank you.
Thank you so much, sir.
Just to ask one question, ma'am. So, if there's a canalicular injury and the patient present after 1 day or 2 days, at that time, can we repair that canalicular? Or how much time we can wait?
Absolutely. Canalicular injuries are not ocular emergencies, though they say it as early as possible, remove it. Do the repair, but you can do repair even after a week's time also. It's bit of a challenge, but you can definitely do it.
By the time it may get healing.
So there are reports where they say like you can repair it almost up to 11 days. But in my practice, usually by 3 days to 5 days, repair is quite possible, sir. It's not difficult. There is no emergency. Prioritize your treatment plan according to the treating condition.
Thank you.
Thank you so much.
Thank you. Dr. Nikita? Yeah. Really, it's a wonderful thing that Diwali crackers injury is very common, but fortunately this year it has been reduced because of the government law. But however, I would like to say that I have a bad experience. A 12-year child came with a firecracker injury in one eye. I cleaned everything, then I put it a patch and whatever the management you have given, I've done it. But only thing that because whenever I wanted to see the patient, he always would never open his eyes. So always he keeps both eyes closed. So because both eyes closed, I thought that the injury is basically to the primary eye. But unfortunately, because it's a injury, severe injury to the ciliary body region and iris region, so he developed sympathetic ophthalmitis in the other eye. And all the while I was treating the sympathetic ophthalmitis the other way, and unfortunately the region was very low, poor in those cases. So one has to keep in the mind if there are any cracker injuries, whether the sympathetic ophthalmitis has to be, because nowadays it has come down because of prolonged use of steroids. But however, one has to keep in the mind. So any question to Dr. Nikita regarding firecracker injuries? Any comments, anything from the audience? You want some comments?
It's a nice presentation covering almost everything. Sapna?
Many times I think we miss the intraocular foreign body. It's a very small particle and the entry wound gets closed. We never bothered. So how to detect, because whatever the investigations said, sometimes we miss. The patient comes with a decreased vision later, maybe 1 month or 2 months like that. So what your, guide to your audience, how meticulously you should see the wound of entry? Because very small particles we miss.
So if you are not finding any cause for the condition, we may have to definitely, history taking is very important.
Yeah.
We have to ask for a history of any wound or
Certainly.
injury.
Yes.
And if we are hearing about any wound, then we have specific to that particular injury, we have to look for a foreign body, depending upon the site of entry. Sometimes if you are suspecting a scleral tear, we may have to even do a conjunctival periotomy in that area suspicious to look for any entry wound or something. Then we have to definitely dilate fundus evaluation is very important.
Sometimes you miss, but you said history taking is very important in all these cases.
Yes,
Whether
sir.
the patient was working and how, what was his work place,
Yes, sir.
how did he get injury? That's very important. So thank you, Dr. Sapna. Dr. Nishita, yeah, one question to you. You said in that the 35 millimeter mercury for 7 days, you said. But I think 35 millimeter mercury for 7 days is a too long time. Unless you intervene, slowly the endothelium gets damaged and there is a question of secondary glaucoma and sometimes blood staining also. So I think it's a 25 millimeter for 7 days, it's enough. 35 means it's hardly 5 days to 3 days. It has to be. If you see that it's not getting cleared, hypema is not getting cleared within 3 days, better to intervene and remove the blood. Otherwise you will land in trouble. What is your opinion?
Yes, sir. Even the earliest sign of corneal blood staining is an indication for surgical intervention.
But once a blood stain started, you cannot prevent it. It will
Yes,
go.
sir.
So before that, you have to prevent it.
These are the guidelines given by Watson.
Okay.
In clinical practice, a clotted hyphema of more than 3 days duration not responding to adequate anti-glaucoma measures is an indication for surgical intervention.
Good. Thank you. Thank you. I think, yeah.
Thank you, Nishida. Nicely presented the topic. So, we are concluding. So, by this we are concluding this session. In time we are concluding the session, and we recognize the presence of here.
I'll call Dr. Irshad to give a memento and a certificate to Dr. Vidya or guest faculty.
I just wanted to add one thing. Through the Maharashtra Ophthalmological Society, we just recently did a survey regarding firecracker injuries, in all age groups and which firecracker, and found a significant number of children or people have also a lot of visual disability following that. So we would be presenting this data to the government and try to get some kind of ban or restriction in the kind of firecrackers also. It's very important that the authorities know what kind of damage and injuries it is causing.